This is Sarah with registerednursern.com, and in this video I'm going to be going over burns. And this video is part of an NCLEX review series over burns. And as always, at the end of this video you can access the free quiz that will test you on this condition. So let's get started. What are burns? Burns are where you have damage to the skin integrity. So we're talking about those layers of skin. We have the epidermis, dermis, subcutaneous tissue, and then below that the muscle and the bone. And depending on the severity of the burn, you can have just the epidermis affected, you can have the dermis or the subcutaneous tissue, or even in worst cases, the bone and the muscle can be involved. And here a little bit later, we're going to talk about those different degree of burns. And these burns come from some type of energy source. So you have various types. And let's talk about those. And I would remember these types for your exams. Okay, the first type you can have is known as a heat burn or a thermal burn. And this is the most common type of burn that you usually see in patients. And it can come from various sources, like a hot liquid getting on the skin, can come from hot steam or a fire, etc. Now, whenever you have a patient who has been in a fire, like an enclosed structure, or has like a steam type injury, what are you thinking about? We're thinking about the airway. You're thinking about an inhalation injury, which we're going to talk about in depth a little bit later. So these patients are at risk for the respiratory system being affected because with the fire, the things that come off of the fire where the fire is burning material, carbon monoxide, they can get poisoning. Steam can go in there, affect those upper airways, burn the glottis, and all of those structures that are before the lungs. So you want to watch that. Another type of burn is called an electrical burn. And just like the name says, it's from some type of electrical source. So what's happened is that the patient has got around something that is going to generate electrical current. It's went and it's damaged the skin. But the thing with electrical burns you have to remember is that it not only affects the skin, but it can affect the structures way under the skin. And we're talking about muscle and bones. Because think about it, depending on how strong of a current this person received, it can generate a lot of damage. So one thing you have to watch out for is even though you're looking at their skin, it looks burned, they got an electrical burn, it looks bad, there can be even more damage underneath that skin layer from where that electrical current traveled. So this is what's called the iceberg effect. So if you ever hear that term, that's what that means. The skin looks, not very well, but underneath the damage could be even worse from where that electrical current went. Now, because we're talking about that, let's take it a step further and think of some things that these patients can be at risk for with these electrical burns. So we said our structures involved were muscle and bones. Okay, say this person had a really bad electrical burn, really strong electrical activity that they received. Well, it's going to affect our muscles. One muscle in particular is the heart. How does our heart even pump? Well, it has electrical activity that causes those ventricles and the atrium and all that to contract to pump the blood out of there. Well, if you send in another electrical source in there, it can throw off that electrical rhythm, so they're at risk for dysrhythmias. Also, bone fractures. If the current is strong enough, it can tense up those muscles so much it can fracture bones. And so we want to watch out for cervical spine injuries in these patients. In addition, let's think back to muscle. When a muscle becomes damaged, what can it release in the blood? A substance called myoglobin. We don't really want this in our blood. And also, from where those cells are going to be damaged as well, red blood cells can release hemoglobin. So we got myoglobin and hemoglobin hanging out in the blood. Too much of it can clog up in there, and as it travels to the kidneys, it can collect in the kidneys and cause a condition called acute tubular necrosis, where our tubules in our kidneys are becoming clogged, kidney function's not going to work, they're going to enter into acute renal failure or acute kidney injury and experience those things. So you want to be thinking about that if you see a scenario with a patient who has an electrical burn. You're going to watch their urine for that. Now, another thing is that this myoglobin, hemoglobin phenomenon can also happen with those full thickness burns as well, because the muscle is going to be involved with those if the burn is really severe, especially in those deep partial thickness 3rd degree burns or in the 4th degree burn, the deep full thickness burns. Next type of burn is a chemical burn. And this is where some type of toxic substance has come into contact with the skin. And this can be from various sources again, like powders, gases, even certain foods can burn the skin. Now, whenever we're talking about that, because say it's a powder, it's got on their skin, they can breathe that in. So we have to watch out for inhalation injury as well with those patients. So it's a risky type of burn as well. And one thing let's talk about is we can have different type of chemical burns. You can have sources that are from alkali sources or acidic sources. And which ones do you think would be easier to treat? Acidic, because alkali, the skin is going to have an issue neutralizing that. So acidic burns are a little bit easier to treat than alkali. Next are cold burns, and this is where the skin has just been overexposed to cold, leading to frostbite. You can also have radiation burns, which is from the sun. Sunburns, we see that a lot, especially during the summer. And from cancer treatments as well, radiation therapy. Another type is a friction burn, and this is abrasion to the skin. Patients can experience this in a lot of ways. Some of the most common ways is if you have a patient who's had a car accident, been thrown out of the car, or a motorcycle accident. When they slide across that pavement, they can get road rash, the skin can become burned. Now let's look at the factors that determine burn severity in your patient, because depending on what's going on with your patient, how severe the burn is can determine how many complications the patient's going to experience and what treatment the patient's going to receive. So burn severity depends on several things. First, the burn depth. How deep did that burn go? Did it just affect the epidermis, or did it go all the way down where it's affecting the bone and muscle? And we have partial thickness and full thickness burns ranging from 1st degree to 4th degree. Another thing that can affect burn severity is the percentage of the total surface body area that is burned. And that's where that rule of 9s comes into play. So usually if a patient's had 15% to 25% or more of a body surface area that has been burned, that's a really bad burn, and they're going to have a lot of complications because the capillary permeability is going to increase, which we're going to dive in a little bit later into the patho behind a burn. Another thing is age. Patients who are really at risk are children, of course, because they are small, they can't handle the damage that's went to their skin, along with elderly patients because their skin integrity isn't what it used to be, along with they have usually a lot of medical issues already. And that ties into a medical history. What's going on with your patient before they experience the burn? Are they diabetic? Well, they already have compromised circulation. So really healing that tissue, recovering from this burn is going to be a lot harder. Or heart failure, where that heart muscle is weak. So when we have all this shifting of fluid, that's going to cause a lot of stress on the heart. And the location. This is huge. This plays a big role in burn severity. Is there burn on their face, their head, and their neck? What do you think is going to be an issue? Our respiratory system. Anytime you see a scenario saying a patient has a burn on their face, neck, and head, think respiratory. Also, their torso. Especially if they have it on the front and the back. What can happen? Especially if it's a full thickness burn, eschar can develop. It can restrict breathing and they can have issues with that. Also the perineum, think infection. They're going to have issues keeping that wound free from infection, and that really is our goal during that acute phase of burn management, is preventing infection. And again, did that patient suffer an inhalation injury? That makes treatment even more complicated if they experience one of those as well. So now let's switch gears and let's talk about the layers of the skin, because what we're going to go into is we're going to go to the different depths of damage that a patient can experience from a burn, which we're talking about the degrees of burns. So let's talk about skin layers. Okay, so what's our top layer? What's it called? The epidermis. And it's very thin compared to the dermis, and it keeps us protected from environmental hazards, and it's great in preventing infection. So if we lose that layer, we're at risk for infection. Now below that is the dermis, which is thicker than the epidermis, and it contains blood vessels along with nerve endings, our sweat and oil glands, and the cells that help create new skin cells, which is why when patients have a really deep burn that is affecting this dermis where it's gone, they're going to have issues with remaking skin cells. They're not going to make them, so they're going to need skin grafts to help generate new skin. And below the dermis is the subcutaneous tissue, also called the hypodermis, and this contains fatty tissue or veins, arteries, nerves, and it helps insulate the muscles, bones, and organs. So it's very vital in regulating our body temperature. So whenever we're getting down into this layer with a burn, the patient, this is like a full thickness, the patient is going to have issues with regulating their body temperature. So when we're providing care, we need to make sure that room is warm, at least 85 to 100 degrees. Now, that's hot, especially whenever you're putting on all that protective gear to provide care, but that needs to be for the patient to keep them warm because they can't regulate their body temperature. So now, since we're familiar with the layers of the skin, let's talk about burn injury depth. Okay, we're going to be talking about first-degree burns, which are superficial burns. We're also going to be talking about second degree, which are your partial thickness burns. And this is where we're getting down into the dermis. And you can have various depth in these second degree burns. You can have superficial partial thickness, or you can have deep partial thickness. Next, we're going to talk about third degree burns, which is where we're getting into the full thickness burn, so pretty severe burn. And we're going to be talking about fourth degree, where this is deep full thickness. So first, let's talk about first degree burns. And as you can see in this picture, first degree burns is going to be limited to the epidermis, so that top layer of skin. And whenever you assess the patient, what you're going to see, it's going to be very red or pink. The patient is going to say it is painful. And why is it painful? Well, it's affecting just that top layer. So that patient still has all those nerve endings there so they can feel sensation. So they're going to complain of pain compared to if you have a more severe burn. It will be warm to the touch. There's not going to be blisters or scars left behind because we're just dealing with that top layer. And if you touch on it, like for blanching purposes, you will see a brisk capillary refill. Next type is our second degree burn, and this is going to extend down into the epidermis and the dermis. And again, severity can vary. It can really go deep down into that dermis where it's almost going into the hypodermis, which could easily make it turn into a third degree burn. But this again is going to be very painful to the patient, and it can be shiny and moist, as you can see in the picture. Also, it's going to be red and pink, and you're going to see blisters present with this, and scars can be left behind, especially if those skin cells are being affected. And a lot of times, if this is a deep partial thickness, the patient will need a skin graft, and blanching is usually still present. Next burn type is third degree, and this extends into the epidermis, the dermis, and the hypodermis, so the subcutaneous tissue. So with this, your epidermis and your dermis are destroyed, which is going to include those hair follicles, sweat glands, and nerves. And because it's going all the way down into that hypodermis, the subcutaneous tissue, so it's a pretty severe burn. And it's not going to be painful for the patient, or the pain is going to be dramatically decreased. And why is that? Because those layers that contain those nerves for sensation have been destroyed. And with this, because those skin cells that would help regenerate new skin have been destroyed, the skin is not going to heal, and the patient's going to need skin grafting with this. Now, let's look at assessment. Okay, whenever you look at a burn that is a full thickness, third degree, what's it going to look like? Well, it can have various colors. It can look black, yellow, or red, and it's going to be dry, matte, instead of being moist and shiny like in that second degree. Now, there can also be some hard areas within that burn, and these hard areas are called eschar. Now, what is eschar? Well, it's developed due to severely burned tissue that is dead. And whenever this tissue has become so burned, it's not working anymore, it becomes really hard and leathery. So let's think about this for a moment. If we are given a scenario and it says this patient has full thickness circumferential burns on their torso, so we have these full thickness wounds on the front and the back of the torso, and it's really hard and leathery, we have all this swelling going on, what do you think is going to happen with breathing? This patient's not going to be able to breathe because it's going to act like a tight band around the chest. And this can also happen with your extremities. So if it's a circumferential burn on, let's say, the right leg, well, that hard tissue is going to just squeeze or not allow circulation to go to that distal extremity, so that right foot. So you can have issues with that. And we're going to talk a little bit more about that with our complications. So always note the location of that circumferential burn, and if it's talking about full thickness, because that's where you get your eschar. And for treatment, for this wound to be able to heal, if eschar is present, it's going to have to be removed in order for it to heal. Now let's look at 4th degree. Okay, this is the worst of them all, and this is going to affect the epidermis, the dermis, the hypodermis, the subcutaneous tissue, all the way down to the muscle and the bone and the ligaments, so all of it. And it appears, when you look at it, it's going to appear black, charred with eschar, and all sensation is totally gone. And of course, these patients are going to need skin grafting, probably cosmetic surgery, and a lot of things like that. Now let's talk about burn location, because that's another big thing that determines our burn severity. And on your exams in nursing school, they love to throw out scenarios about patient has a burn on the face, the neck. What are you going to be looking for as the nurse? What are you going to assess? What's your priority? So let's quickly go over these different locations and hit the highlights of things you should be thinking about if you're giving those scenarios. Okay, let's talk about respiratory. What areas, if burned on the body, are you probably going to have some respiratory issues with? Well, a burn on the face, because this is where breathing starts. We inhale, and this is where breathing really stops because we exhale through it. And if we can't get air in or out through this area because it's burned and all that swelling that's going on, we're going to have respiratory issues. So especially those burns on the nose and the mouth. Also on the neck, because again, we help airflow up and down that. But if we have swelling, it's going to close off our windpipe to allow us to breathe. And of course, the torso, and that's where I was talking about those circumferential burns with those full thickness burns, like a band around that chest, impeding the patient's respiratory effort to breathe in and out. So if you see that, be thinking that. Along with, if your patient has a burn on the face, the nose, you really got to be thinking about inhalation injury as well, which we're going to go over here in a moment. Next, trouble healing. What areas on the body of burn do you think are going to have really a big issue with healing because they have a poor blood supply to them? Well, any structure that's really made out of cartilage, they don't have a lot of blood flow to them naturally. So we're talking about our ears and our nose, which is going to put them at risk for disfigurement because it's not going to heal very well because it doesn't have a nice blood supply going. And we're talking about infection, definitely at risk for infection, especially those ears. And we're going to talk about in our nursing interventions, you've got to be careful positioning a patient's head when their ears are burned. Disability, what area on the body, if it's burned really bad, the patient, once they heal, they're really going to be disabled, and it's going to affect their life compared to if they just have a burn on the thigh or something like that. The eyes, vision will be gone, or the hands and the feet, because these structures are very delicate. And when a patient has a burn on the hands or the feet, very severe burns, they're really hard to heal, and they can have a lot of complications like contractions, things like that. So the patient's going to need a lot of physical therapy. And compartment syndrome, we talked a little bit about that earlier. What areas are going to be at risk for compartment syndrome? Our extremities, who have experienced full thickness circumferential burns where that tight band of eschar is just impeding circulation. So you have a scenario, it says that your patient has that, be checking those pulses in the feet, what does the color of the foot look like, and so forth. And also, if you have it on the torso, you want to be thinking about that as well with the respiratory. And infection, what areas are going to be really prone to infection? The perineum, the bottom, because those are just natural routes where elimination happens. And if we're trying to keep a wound clean because they're already at huge risk for infection, it's just going to double down on a huge risk for infection, sepsis, and things like that. Now, we talked about total body surface area being affected, that determines burn severity. If we have really high percentage, anywhere from 15, 25 or higher percent, that's going to change our capillary permeability in the body, which leads to all this fluid shifting and problems. So to determine that, we like to use the rule of nines, and I've made a whole video on the rule of nines that you can access. Has a quiz that's going to test you, give you some sample problems that you can work and get practice with that, because if you're going over burns in nursing school, it's a very high probability that you're going to have a question on your exam about the rule of nine. So be sure to check out that video. Another thing that determines burn severity is, did that person suffer an inhalation injury? Now, what is this exactly? Well, it is where there is damage to the respiratory system due to that person breathing in some type of substance that shouldn't be there, that's damaged or upper or lower airways. And these substances can vary, like smoke, carbon monoxide, and carbon monoxide poisoning. It's colorless and odorless. It's really hard to detect. Also, from thermal type burn, from the heat, like a hot liquid or steam, or a chemical like those powders and gases. And usually this is a high cause of death in fires, the inhalation injury. And your upper and lower airways can be involved. Typically the upper airway is the biggest area that's involved rather than the lower, because the lower is really protected by the glottis and the vocal cord structures. So really the upper airway is what happens, and then it causes a mechanical obstruction where air cannot go down into the lower airways. So let's talk about carbon monoxide poisoning. Okay, what's happening? What's going on? Well, like I said, you can't really detect it. The patient doesn't know that they're breathing in carbon monoxide. And what happens is they breathe this in. And let's talk about the red blood cell, because this is who's really being affected with this. Okay, our red blood cell, one of its things that it does is it transports oxygen throughout the body. So our organs and tissues can be replenished. Well, what on that red blood cell helps it do that? Hemoglobin. Okay. Normally, hemoglobin will carry the oxygen throughout the body, and they have a really strong connection to each other. But once you introduce a lot of carbon monoxide, the red blood cell, that hemoglobin, starts to prefer carbon monoxide. So carbon monoxide takes over on this red blood cell, and there's no more oxygen left. Well, that's a huge problem, because instead of transporting oxygen throughout the body to replenish our tissues and organs, it's going to transport carbon monoxide, and our body doesn't like that, and it will kill us if it's high. And how do we measure that? Well, they will draw labs and they'll check what's called a carboxyhemoglobin level, and if carbon monoxide poisoning is in the patient's system, it'll be greater than 15%. So what can you see in these patients? You're going to see neurostatus changes. They're not getting as much oxygen as they need, so they can even go into coma. They'll be confused. They'll be drowsy, headache, nausea, dizziness, and they can have, some patients, if it's really severe, they can have this bright cherry color to their skin or to their lips. And what's treatment for this? From a nursing standpoint, I would remember this. Treatment is 100% oxygen on a non-rebreather mask to help replenish that oxygen in the body, because the patient needs it. Now let's talk about what are some signs and symptoms that would tip you off that a patient may have suffered an inhalation injury. What could you expect to see or find in your patient? Well, first of all, you need to investigate where this patient suffered this burn. Was it in an enclosed structure? That means not ventilated very well. They can be at risk for inhaling smoke and other substances. Also, where are the burns located? Are they on the face, the nose, the mouth? Be thinking, possible inhalation injury. Also, is the patient having sputum that looks a little abnormal called carbonaceous sputum? And this is where the spit literally looks like it has black soot in it. Does the patient have hair singeing on the head or the nose hairs? Think inhalation injury. Or is there black soot around their nose or their mouth? And of course, are you seeing the bright red lips, the cherry red skin? Think carbon monoxide poisoning. Is the patient having trouble talking to you? Is their voice hoarse where those upper airways have been affected, those vocal cords? And are they confused? Are they having anxiety from where that respiratory system is being compromised or not getting the oxygen transferred throughout the body, so it's causing mental status changes? Or do they have an increased heart rate, which goes along with the decreased oxygen? The heart's trying to compensate for that by increasing its output. Now let's switch gears and let's talk about the phases of burn management. This is going to help us whenever we're talking about the physiology of burns, because physiology of burns and nursing interventions really go hand in hand, and we're going to cover that next. But I want you to be familiar with the phases, so if I refer to them, you'll know what I'm talking about. Okay, and to remember the phases, whenever you put the beginning of the words together, it forms an easy word, and it's ear. So remember the word ear, and that'll help you remember the way that the stages fall. Okay, the first phase is called emergent, also called resuscitative. And this is where you have the onset of the burn injury, and it ends with the restoration of capillary permeability. And this phase lasts about 24 to 48 hours depending on how severe the burn is. Now, during this phase, the patient is at risk for some things because we have an increase in capillary permeability, which we're going to learn about here in a moment. And this can lead to hypovolemic shock, also respiratory distress due to all the swelling, and again, that determines where the burn's actually located, and of course, compartment syndrome, and that goes again where the burn's located as well. Then we have the next phase, which is the acute phase. And this starts when capillary permeability has stabilized, so it's corrected itself, which is going to turn into diuresis because we had all this fluid shift outward, and now it's coming back into the intravascular system. And it ends to the closure of the wound, the burn. And it typically starts at 48 to 72 hours and ends when that wound heals. And our focus during this phase is preventing infection, alleviating pain, ensuring proper nutrition, and providing wound care. And the last phase is known as the rehabilitative phase. And this is where the burn's healed, so it starts with that, to the patient being able to function again. And this would include mentally and physically. So the focus during this would be psychosocial, activities of daily living, physical therapy, occupational therapy, and cosmetic correction if needed. Now let's talk about burn physiology, what's going on in the body, and the nursing interventions. And what I'm going to do is I'm going to mesh the two together because it makes so much more sense why we are doing this nursing intervention based on what phase this patient's in and what's actually going on during this phase. So it helps you remember it better. Okay, what we're talking about, whenever we have a big change going on in the body, and as you're going to see with burns, it literally affects everything. That's why patients can die from this. What we're talking about is a severe burn, like one of those full thickness burns, or we're talking about where they've had all those risk factors for burn severity and they've had a high percentage of their body burn. They're going to go through this. They're not going to go through this if it's like a really minor burn. So keep that in mind. Okay, so we have a really bad severe burn. The patient is burned like 40% all over their body. We're going to have a major change in capillary permeability, and this is going to happen fast. About 20-30 minutes after burn, this can happen. And what happens is that we have our intravascular space. So be thinking that. That's where we are right now. And within that, what's in that space? We have our blood, which is plasma, and suspended in the plasma are red blood cells, white blood cells, all of the substances in our body that we need to survive. Well, that capillary that's really holding that changes its permeability. And in a sense, what happens is that plasma starts spilling out of that intravascular bed, and it leaves the intravascular system and goes into the interstitial tissue. So it's leaving there, and what's going to follow that plasma as it's leaving the interstitial tissue? Sodium. So our sodium level is going to drop. It's going into the interstitial space, so the patient can have hyponatremia. Also, albumin can follow as well and move outward. Now, we've talked a lot about albumin. What does albumin do? It regulates oncotic pressure, which helps, in a sense, in a nutshell, regulate the water within that intravascular system. And if you lose it out of the intravascular system, the water, the fluid is going to space other places other than there. So we're going to have problems with edema even more. Now, because we have depleted our intravascular system, that plasma has left that nice capillary area, what do you think is going to be happening to all the other substances that are left in there? It has no fluid left to suspend it. It's going to become really concentrated, specifically the hematocrit. So you can see an increase in the hematocrit level, and then whenever the patient is replaced with fluids, the capillary permeability stabilizes. In the acute phase, you're going to actually see a decrease in it. So remember that. And another thing is that the blood is going to become very thick because the plasma is gone, and this is going to affect microcirculation as well because it's just really thick inside those little areas of microcirculation. Potassium, what do you think is going to happen to potassium? We have an injury to the burn, the cell is affected, it's messed up, and what's nice inside of our cell? Potassium. Well, whenever that cell breaks open from the damage, it's going to leak potassium into whatever's left into that intravascular system. So we're going to have hyperkalemia. Our potassium levels will increase. White blood cells, they're going to go down. They were there as well. They've been injured with this injury. Also, those immunoglobulin, those proteins that help us fight infection as well. So from a nursing standpoint, we've got to watch for infection. We've got to do things to prevent infection because they don't really have a system to help fight infection. Plus, they just lost the layers of their skin that help protect us from infection as well. We've got to watch for signs of hyperkalemia and hyponatremia. So we've established that that intravascular system has no fluid in it, which isn't good because that fluid plays a huge role in allowing our heart to pump all the blood to our vital organs. So if you don't have a lot of fluid for the heart to pump, what's the heart going to do? It's going to try to increase itself to pump harder. It's like, if I can work harder, I can pump more blood. So you're going to have an increased heart rate, but there's nothing really to pump, so cardiac output is going to go down and blood pressure is going to go down. Well, our vital organs suffer from that, and they don't like that, and they can die, especially our kidneys and our GI tract, and all that's going to be affected. And the patient can enter into hypovolemic shock. And that's the big thing we're trying to prevent in this emergent phase is hypovolemic shock. And that's why we're throwing all these fluids in on this patient to prevent this from happening, because we want to maintain the function of those organs. So now let's talk about those organs that are being affected. First, the renal system, the kidneys. Okay, initially our patient is going to be aughluric because of what is going on and the fluid volume deficit, because all that fluid's moving out. And one thing, remember, I told you to remember about the full thickness and the electrical burns, because muscles can be involved with those. As the nurse, you're going to be monitoring that urine for myoglobin and hemoglobin, because if those collect in those tubules, it can cause acute tubular necrosis, in the end lead to renal failure. So you'll be monitoring that. Now these processes switch. So patients in emergent phase over here, then they go into the acute phase within about 48 to 72 hours. And what's going to happen during that is that all that fluid outside that capillary bed, which is in the interstitial tissue, is going to move back into the intravascular system. Whenever that happens, kidneys are going to have to get rid of all that fluid. So you're going to see diuresis during that. So those processes really switched. And as the nurse, patient's going to have a Foley, and the best indicator of our patient's fluid status is their urinary output. So you're going to be watching that very closely, and you want it at least 30 cc's or 30 milliliters per hour. Now, let's go and talk about fluid replacement, because during the emergent phase, this is the most important thing that we're trying to do, along with preserving their respiratory status if they have respiratory problems, but we're also looking at that circulation status. So crucial fluid replacement over those next 24 hours. And a lot of times they use what's called the Parkland-Burn formula. This is a formula used, it's based on how much the patient weighs, their total body surface area that has been burned, based on amount of lactated ringers that they're going to give over the next 24 hours. And I have a whole video that you can watch where I work a problem and there's a quiz along with it, and you can work some sample problems to help prepare you for your exam. So check out that video. Now, nursing-wise, you want to make sure that your patient has IV access, because fluids are crucial. So you need at least 2 IV accesses or a central line that can handle all the fluid resuscitation. Fluid-wise, a lot of times lactated ringers are given, LR, and what they do is they expand the intravascular compartment, which is what we need and what's going on with this situation. Also, colloid solutions like albumin will be given, and we talked about why that was over there, because the albumin left and went into the interstitial tissue. We need to replace it so we can help get that fluid back into that intravascular system, because that's what albumin does. It attracts water, and we give that to them and it'll pull that fluid back into the intravascular system. And again, monitoring that urinary output, because you're going to be titrating these fluid amounts based on how much urine they're putting out. So if they're not really, say they're only putting out about 10 cc's an hour, well, let the physician know, probably going to tell you to increase the fluid rate so they can get some more fluids. But whenever they are getting fluids, you've really got to watch out for fluid volume overload. Are you giving them too much? How can you know that? Listening to their lungs, do they sound wet, crackles, the swelling, edema, is it getting worse, and things like that. Now let's talk about that edema. You get edema because just the nature of the injury, but the albumin's leaving and the fluids are shifting to that interstitial tissue, which can cause us a lot of problems. And we're hitting back on circumferential burns again, and we got to watch out for this with those patients who have those full thickness burns, because what can develop? That really burnt tissue called eschar, which will act like a band and prevent respiratory effort or circulation. So we're going to look for compartment syndrome. And whenever you have circumferential burns on the extremities, nursing-wise, what you want to do is you want to elevate those above the heart level to help with the edema, decrease that edema, because the swelling, the eschar, all that together is not a good thing, because it can decrease circulation to those extremities. Now, sometimes if it's just really bad, they may have to perform an emergency escharotomy. This is where the physician will go and cut those bands of dead tissue, that eschar. And whenever they do that, that relieves pressure to, if it was on the torso, the chest, the extremity, and they will feel better. And how you can look to see if that was successful or not, you can look and feel the pulses in that extremity that was being affected. What's the skin color? What's the capillary refill? And respiratory, if it's on the chest, is the patient breathing better? So that would tell you if it was successful or not. Another system being affected by a severe burn can be the GI system. And why is that? Why would a burn affect the stomach? Well, what happens, remember, just like with the kidneys, they've lost perfusion, so they're going to be affected. The stomach has received decreased perfusion. And remember, in the stomach, when we went over a GI series, we learned that there's a lot of cells in there that secrete like bicarb and other things that help keep our stomach lining nice and protected from the gastric acid in there. So those two can survive together. And what happens is you have decreased perfusion to those handy little cells, and then you have increase in acid production due to the stress response on the body. So that makes perfect conditions for an ulcer to develop. Specifically in the duodenum is where they can happen. And they're called Curling's ulcers, and a patient can report like pain that's just like gnawing in their stomach. They can have nausea, vomiting, and blood. So as a nurse, you'll be assessing them for that and looking at their stools for blood, because it can leak into there. And what patients are typically given, they're not as prevalent as they used to be in burn patients. because they get treatment with antacids and things like that. Another thing that can happen is that they can experience what's called an ileus. This is literally where the gut is just not working anymore. And what's happening is you're getting decreased function from the decreased perfusion, among other things, which is leading to decreased motility. So it literally just freezes and stops. So as a nurse, you want to be listening to bowel sounds. Do you hear bowel sounds? And another red flag, a lot of my patients who've had ileiuses, they have had vomiting where they're throwing up this lime green vomit. And it's where whenever they've ate, the food is just literally staying stagnant in their stomach and it has to come out. So you see that, think of that as well. You're going to keep the patient nothing by mouth because of everything that can go on. They're going to have a nasogastric tube in there to remove air and secretions. And then once the bowel sounds return, they're hitting that acute phase, they can start getting food, because how do you think their calorie needs are going to be? They're going to be very high because they have a lot of percentage of their body burn. They need calories for the body to work and to help rebuild and repair. So a lot of times they may have like a central line to get nutrition that way. Dobhoff's feeding tubes can be inserted and they'll get feedings, and they need high calorie, high protein, and high carb vitamins and foods and things like that to help with their healing. Now, one thing you got to watch with these patients is that they may have hyperglycemia, where they have an increase in their blood sugar. So you're going to be checking that, looking at that. Now, why is that? Well, the stress response with the catecholamines, everything being released, is going to cause the liver to release glycogen, which is going to increase that blood sugar. So you may see that as well. Another system that is affected, of course, is the respiratory system, especially if they have burns on the face, on the neck. So you want to be thinking about that as a nurse. Where are their burns located? A lot of times these patients are going to be intubated fairly fast if they do have burns there because of the swelling that comes afterwards. Also, you want to be making sure and asking yourself, is this an upper airway problem? Because that can mechanically obstruct the airflow, or do they suffer a lower airway problem where some toxic substance got down in there in the lungs and it's damaged the alveoli sacs, which is going to impair gas exchange. So you'll be watching the respiratory effort, looking at that, monitoring their ventilator settings if they're on that. They'll probably have an arterial line. You're going to be looking at their ABGs, drawing a carboxyhemoglobin level just to confirm no carbon monoxide poisoning. Remember, levels greater than 15% are not good. And a lot of times, a little bit later, if they need to confirm an inhalation injury, they can do that with a bronchoscopy. Another system affected is our immune system. So what does that put the patient at risk for? Infection. Why is that? Because they've lost the protection from the skin. It's gone, it's burned, so we're at risk for the outside germs in the environment. And the cells that help us fight infection are gone and damaged, so we're at risk for that. So as the nurse, we got to do some things to help prevent infection, because this is a huge risk during that acute phase. Okay, protective isolation is what they will be in. We're protecting the patient from us, from visitors, from outside things that can cause them harm. So whenever we provide care to a patient with severe burn, you want to wear a hair covering, gloves, gown, a mask, and shoe coverings. Don't want to take anything in that room to hurt that patient. Also, linens are going to be sterile, covers, and whenever we do wound care, we'll be using sterile gloves. And it's important that you assess the patient's last injection of a tetanus shot, because they're at risk for developing this, and if it's been at least 5 to 10 years, they may need another injection. Another thing is temperature regulation. They've really lost their ability to regulate their temperature, especially if that hypodermis, that subcutaneous tissue, is being affected. Really can't regulate their temperature, because that's what helped us do it. So the room temperature needs to be anywhere from 85 to 100 degrees Fahrenheit. You're going to look at your patient. Are they shivering? That's not good. So they need to get warm. Next, pain. We want to make sure that we're addressing their pain because burns are very, very painful, especially whenever they start having wound care and things like that. So on a test, what option are you going to select? What route is the best for the patient who has had a burn? The IV route. Why is that the best? Well, we don't want to do oral because we just learned the GI system is really shot. It's not doing good. So we can't really determine how effective that medicine is going to be when they absorb it. So we don't want to do that. Sub-Q, yeah, their skin integrity is messed up. We can't measure how it's being absorbed. And IM, not only is that painful, but again, the muscles can be affected with burns. So IV is the best. Another thing is wound care. Various types of wound care really depends on the physician, the hospital protocols, what they do. But you can have various methods. You can have the open method where there's a topical antibiotic ointment that goes on the burn and it's left open to air. Nothing's covering it. Or if it's closed, topical antibiotic ointment goes on. They use some type of covering over it like sterile gauze or something like that. And again, pre-medicate before wound care. If you get a test question about that, you're going to do wound care. What are you going to do first as a nurse? Pre-medicate. And the wound needs to be clean. They can do this with hydrotherapy or shower. Very painful. Again, debridement. They have to remove the necrotic tissue from the burn or wound healing won't help. So they'll have to do that. And again, that's very painful as well. Now with healing issues, this is going into the acute to the rehab phase. So we want to make sure that we never have two burn areas touching each other because webbing can occur. So always make sure you don't do that. And for pillows, avoid using pillows whenever you have burns to the ears and the neck. Why is that? Well, the ears, the circulation, as we already learned, is compromised. So if we have a pillow on the ear that's already compromised, that can decrease circulation even more, affect healing, cause it to go necrotic. Or with the neck, it can cause what's called contractures. And this is where you have tightening of that burned skin. And they're going to lose their mobility with that if it's not corrected. So we don't want to do that. And speaking of contractures, physical therapy will be working with them a lot with range of motion and splinting to prevent that. Okay, so that wraps up this lecture over burns. Thank you so much for watching. Don't forget to take the free quiz and to subscribe to our channel for more videos.